Welcome, everybody. This is a very special day for our department. This is the 5th annual University of Miami Jackson Health System Technology Symposium cranial session. We've had a very successful spine session. Alan Levy couldn't be here today, so I'm standing in for him and delighted to welcome our supporters who are here and who have generously given support to make this happen. So the sequence of lectures today will be Bobby Stark, who will talk about endovascular technology updates for aneurysms, to be followed by Eric Peterson, technology innovation. I will talk about bypass surgery for ischemia. And last, Mike Ivan will talk about some exciting brain tumor surgery innovation. And then please, let's spend some good time with our generous exhibitors and supporters out there. There is some exciting equipment they'd like to show us. We'd like to thank Acumed, Codman, Specialty Surgical, DB Surgical, Penumbra, and Stryker. And here we are. And really, really thank you for making this happen, help us do this education mission with our residents, our fellows, the people who are joining on Zoom today. And without further ado, Bobby, come and dazzle us with some endovascular stuff for aneurysms.
All right, thanks so much for giving me the opportunity to talk today. And thanks so much for all the people and companies that help support today, but also help support our patients, their families, and our research. So we'll try and blast through some of the technology updates in the treatment of cerebral aneurysms, primarily focusing on endovascular updates. So my funding disclosures.
Use the keyboard, doctor. The keyboard, left and right is the best.
Okay, so my training up there, I always think it's important to always think about how we got here today. I trained in primarily open and endovascular, and certainly my friends would tell you I became a complete tool at some point in my training. But I think that's part because if you just have a hammer, everything looks like a nail, even if it's a rabbit. And sometimes when you put these two things together, you end up with a lot of nails in your head. And then part of that also, I think for that, that the long training was I didn't know that I'd be surrounded by such great partners in both open and endovascular. So I think all those things are important, for the younger people that are going through that stuff, making those decisions now. So I think we do see a lot of interesting things in Miami that, potentially we don't see elsewhere. Quick case start. This is a 23-year-old medical student complained of severe headache while studying. She collapsed. She arrived comatose with hydrocephalus. She didn't improve with an EVD. She had multiple strokes on MRI, in part because it took her a number of days to get here. She had severe ARDS, went into pulmonary failure, DI. This was her original film. So we went on to clip her aneurysm. On day 10, she was still comatose. On day 12, she had minimal movements. We were talking about withdrawing care. But over sort of the long time, she went on to make an amazing recovery. A couple months in rehab. Ultimately went back to make a complete recovery and just wrote her first paper just recently. So I think it's easy sometimes when we see how badly some of these patients look like they're doing, that it's easy to forget that they can still go on and make incredible recoveries. So I think aneurysms, pretty extensive, different types of aneurysms in terms of morphology. This is a tiny ACOM blister versus this is my wall of giant herniating aneurysms. And I think we're all pretty familiar with the common treatment options of clipping and coiling. In terms of open surgery, still advances being made, but a lot of things haven't changed that much. This was a giant aneurysm that we trapped and bypassed. And this was the picture of the craniotomy. And when I was doing my training with Dr. Cassell, every patient got what we call the flap of crap, this giant, massive incision, for all aneurysms. And we, changed that over time for for clipping to become less invasive. This is a younger patient with 3 aneurysms here. You can see here through, pretty much a 1.5 inch craniotomy, we're able to go down, clip all of those aneurysms. Patient basically goes home the next day with a Band-Aid. Another patient with, this is a patient that had a previously coiled ACOM, basically through a tiny, you can see here, maybe a 1 inch orbitozygomatic craniotomy. We're able to go down and put a clip on this. And, the nice thing about this is this is completely permanent. But certainly, if I had to choose between any of those things and just someone poking me with a needle, I'd much rather have a minimally invasive option. It's important to remember that minimally invasive is not always better. And, all these things need to be balanced. This is a patient that was coiled 7 times at another hospital after a subarachnoid hemorrhage, came back in with another subarachnoid hemorrhage. They shot both femoral arteries. You can see here, they were occluded. They felt, okay, that's a good time to send the patient over to us. This was the radial approach. You can see here this massive blood again of the coils and the aneurysm. And this, the only really reasonable option in this case was clip reconstruction. So, thinking about these types of images, certainly we've got to be doing things better in the next, 5, 10, 15, 25 years, which is a lot of what motivates me on a regular basis. It's pretty impressive that we published this review in 2016, and still a lot of these devices are still making their way to us or in various phases of development. And it's certainly part of the reason I took the job here at University of Miami. This is the research lab where we have biplane angiography, MRI, CT, ultrasound, and that's just for research purposes along with surgical suites. So I'm really going to skip through this for the interest of time. These advances in endovascular treatment of aneurysm go back to before the 1940s. And really, you can see here every 10 years, there was sort of a new device or something. But then starting about 2000, there was really an explosion. And if this goes up to 2020, you can see all these different advances. But 2012. But in 2012, there was just a tremendous explosion, and we would need numerous slides to go through all these things. But let's briefly talk about some of the advances, and we'll go through imaging, treatment, medical therapy, and I'll try and stick to time. I know we're running a little bit behind. So see, these are some of the new imaging modalities that we and others are working on that are going to help us in the future. So 3D imaging is something that we regularly use on a daily basis, but that's getting better and better in terms of reconstructing images from angiography machines to better understand how the vessels interplay with the bony anatomy and things like that. We can see here now with new devices, new stents. You can see here on the right, a clip, EVD, things like that. We're able to reconstruct these images into better and better fashions. 4D imaging is a reconstruction that can be made either through MRI or angiography, and it can allow us to quantify flow, hemodynamic stress, and actually measure a lot of the factors that are important for aneurysms. MRI Nova is another non-invasive technology that allows us to actually quantify the amount of flow moving through vessels, but also determine the direction. We have a lot of new protocols in terms of looking at stents and things like that. This is a dual energy CTA stent protocol. You can see here on the old image on the left, it looks like the stent is occluded versus the one on the right. You can clearly see that there's contrast going through the stent. Microangiography is something that's coming a long ways where we'll be able to see down to a sort of a microcapillary level. And I think that's going to be something that's going to come, significantly further in the future. A lot of new modalities for intravascular imaging. So this is intravascular ultrasound through a tiny microcatheter, commonly used in cardiology. Optical coherent tomography is something that we've been working on in the lab here for quite some time, which actually uses a infrared laser within a microcatheter and can take a video from inside the blood vessel wall. And you can see here, this was our previous publication in Stroke reviewing this. You can see the stent tines here on the lateral image along the inside of the vessel lumen down to sort of the endothelial level. Other modalities of intravascular imaging, this is actually almost like an exoscope that goes inside the vessel and gives us direct images from within the vessel. Confocal microscopy is something that's been around for now hundreds of years, but this has now gone down to much larger micro level where we can do 7 stains and really section at the tiniest level. This is going to come a long ways in the future for our patients as well. Molecular imaging and both antibody imaging are other things where we can attach either a certain antibody to look at molecular changes, things like that, that will look for inflammation, other elements. Here within the aneurysm shows active aneurysms. So I think imaging is going to go a tremendous way to help us select patients, determine which patients are at higher risk, and pick up on aneurysms potentially before they're growing or rupture. For endovascular devices, I mean, we could spend hours talking about new devices, but we'll try and just briefly blast through some of the major updates. Are significant improvements in microcatheters. Now we have microcatheters that we can drive, we can rotate in different directions using handheld switches. This has allowed us to treat more complicated, challenging aneurysms. Here's a dual microcatheter technique where we put two microcatheters into a wide-based aneurysm to treat that, and we published on that a number of times in the past. Improved guide and distal catheters. There's really been an explosion in this, in part due to the tremendous advances in thrombectomy for stroke. I mean, it seems like almost every day we're getting or evaluating a new catheter that's more trackable or more supportive, or really is designed for a very specific instance. I think Eric will talk more about this, but this is the catheter that he designed specifically for radial approaches on the cover of JNIS, the wrist catheter. And then we've also looked at, extensively radial approaches, which has increased our ability to treat aneurysms endovascular. This was a national comparison of radial versus femoral approaches for flow diversion, showing that the radial approach is safer. Liquid embolics are coming a long way, still don't have a major impact for aneurysms, but we're trying a lot of different things. You can see here, this is for mycotic aneurysms. There's a lot of new embolic agents coming, and this hasn't drastically changed how we're treating aneurysms in the last 5 years. But I do think that an embolic agent can fill the dead space of an aneurysm much better than a coil. And there's a lot of companies. I can't talk about anything that I've signed an NDA or that's in development phases, but a lot of companies are working on like an embolic agent that could fill the aneurysm. Larger diameter coils are becoming much more common. This is one of the really giant penumbra coils that has a larger inner and outer diameter, so you're using less coils to coil aneurysms. Stryker had these major advancements in target coils, which allowed us to use longer coils, and I think this is really coming a long way. This was a giant aneurysm where we sacrificed both of the vertebral arteries after doing a radial artery bypass. And basically, you can see here on the vertebral arteries that we sacrificed, that's 2 to 3 coils, probably took about 5 minutes. Whereas a lot of these procedures in the past, often took hours. So there's a lot of companies that are working on developing larger volume coils from the same coils. And we've looked at a lot of this in prospective trials. This was from the SMART registry, which we contributed to. Penumbra also has a number of other types of coils coming out. The wave coil lacks really a helical shape, and so it can fill potentially dead space more. And this is the SURF trial, which is a prospective trial which we've been enrolling on, is almost completed. Bioactive coils is another thing that's a lot of companies and folks are working on, and unfortunately a lot of the trials haven't shown a major benefit of adding special coatings to these coils, but I do think in the future that's going to provide further benefits for our patients. We have a lot of new coil constructs. So the idea with this is the Medina, and then Stryker has their new device here, which we're evaluating in a prospective study, the Citadel. But the idea behind this is more of a flower device that could frame the aneurysm in a better fashion and hold coils in place, especially for wide-necked aneurysms. So I think that's another exciting avenue. We have a lot of new balloons that can help make these cases easier. And we've looked at a lot of that in the research comparing, stent and balloon remodeling. And these balloons are, more trackable and have a number of different options in helping us fix these aneurysms. Wide-necked aneurysms, we have a lot of new develops in stents, and there's just so many different types of stents. And we've looked at that in sort of Y stenting, single stenting, and really there's, this is just an exploding area. I mean, every day we're looking at new types of stents, new ways that they're making them. And these are some of the various areas that are really developing quickly. So the Solitaire was one of the first stents. We now use it for thrombectomy, but going all the way back to when I was in New Zealand, we had a detachable Solitaire that we were using for aneurysms. Clot developed in that stent during a case, and someone pulled the stent out and pulled out the clot. And that's sort of what part led to using stents for thrombectomy. The nice thing about the Solitaire, and unfortunately we don't have detachable Solitaire in the United States though, is it's very, it's open, it's primarily open cell, and it's a very low amount of metal. And that has led to improvements in a lot of the stents that we use for stent-assisted coiling. So the Enterprise has gone through a number of iterations to improve that stent. The Neuriform is now, the newest iterations are Atlas, and we'll talk a little bit more about that. But stent-assisted coiling has now been around for many, many, many years. This was our prior study published many years ago now in stroke, looking at long-term outcomes of stent-assisted coiling. So the Enterprise has improved in terms of having better visualization of the aneurysm, improved trackability. The Atlas was the update on the Neuriform from Stryker, which has really changed how we treat a lot of aneurysms. And that's because this stent can go through a much smaller microcatheter. It's much more trackable. And you can see here, we can use it for wider bases to ledge the stent to get it to conform along the base of the aneurysm better. The Elvis and Elvis Jr., that has also gone through a number of iterations, but that's stent provides more metal coverage for stent-assisted coiling. We also have a number of different balloons that can use to deliver stents. So we can use a balloon for balloon remodeling. And then if we need to place a stent, the stent can actually be placed through the dual lumen of the stent. A lot of new devices now looking for scaffolding. So a different idea than a stent that might be less metal or might be better for wide-necked aneurysms or get away from Y coiling. So this is the Pulse Rider, which you can see here is a flower device that's good for sort of Y-type aneurysms that can provide a scaffolding for coils. And we've been using this for a number of years. We evaluated this in a prospective study, the NAPA study. And there's really a number of these devices that have been coming out and improving to try and develop ways that we can stent coil aneurysms with sort of a scaffold. The Eclipse is another one of these. And then the Comaneci is another device that was developed from a stent retriever that we can use this basically to use a lever to open or close the stent to provide greater coverage. And this is a removable stent that helps sort of like a balloon. Intrasaccular devices, these have come a long ways. We now have more than 5-year outcomes looking at results of these, and a lot of companies are still developing newer implants similar to the Webb. The Contour, another flow diverting device that's sort of like an intrasaccular device, but also can be a scaffolding like device. And this is coming to us now, or pretty shortly. We'll have trial up and running to look at this more clearly. So some cases that have been done with the Contour device. Flow diversion, that's another area that has really exploded. You know, we have aneurysms like this that previously didn't have any sort of reasonable treatment option. You can see here the post flow diverting stent. Cases like this, the pre and the post. So this really dramatically changed how we were treating a lot of aneurysms, not just giant aneurysms, but now also small aneurysms. Now we have long-term follow-up outcomes in both the original PUFF trials, but a lot of the original studies, you know, that we and others have published. We've also looked at flow diversion. We talked about radially. We published extensively in this area, showing, you know, that sometimes we can decrease complications, improve outcomes through various approaches. The Pipeline Flex was the first of the second generation for flow diverting. And we showed over time that the more that you use these devices, the more you improve with them over time, your complication rates go down, you have a better understanding of how to use the devices. Now, a lot of these companies have moved on to surface modifications to try and decrease the thrombogenicity and improve obliteration of aneurysm. So we're on to the Shield Pipeline Flex, which was a surface modification of phosphatidylcholine, with the idea of hopefully we can get to something that doesn't require aspirin and Plavix. We and others have tested this fairly extensively. We did a lot of the initial testing of this, especially in vivo. We did over, 180 stents in a rabbit elastase model, looking at this stent and how it changes local coagulation and improves obliteration. We did one of the first cases in the country that we got compassionate use for, and this was over, I think, probably about 3 or 4 years ago now. So we're already on to the next generation of that, which would be Vantage. This was a lot of the preclinical testing, both in animals, but also in blood flow models to look at how this changes both coagulation parameters. So They're already on to the next generation of pipeline, which is now the Vantage, which does come in a variety of other sizes. So other flow diverters, Stryker has the Surpass, which has now gone through also a number of improvements since we enrolled 4 patients in the initial trial. This has gone through tremendous developments and advances, partially through improved catheters to deliver Surpass, but now we're on to an Evolve, which is a little bit more of a slinky flow diverter, easier to deploy, easier to recapture. And then just recently, Stryker announced this news release. They're going to be partnering with Carmida, which is a coating for their Surpass or Evolve. And it's a like a heparin derivative that they can use to line the stent. And that was first publication actually in Circulation, I believe, in 2003. So even going back a long ways, where they were looking at this in the cardiac literature, it's finally making its way to aneurysms. The Fred is another device. They've also have now the Fred X, which also they've developed their sort of similar phosphatidylcholine surface modification. And now pretty much it seems like on almost a regular basis, we have new flow diverting stents and also new surface modifications. And I feel like we're testing a new one of these in the lab on almost a regular basis. So size wise, that's been a rapid expansion as well. We just published this paper with a number of other folks. We got compassionate use to use the Silk Visa Baby, which is a micro flow diverting stent that can go down into an 017 microcatheter. So allow you to canalize, really small vessels, which potentially we didn't think were possible before. Real quickly, covered stents, that's one of the last areas that's really developing. This was a young patient with this massive aneurysm. You can see about 12 inches in the neck here that ruptured. And you can see here this giant aneurysm with covered stents. This is immediately obliterated, bleeding stop. So we've got a number of new covered stent options. This is one that we did some of the first cases in the brain in the country. And it's a balloon expanding stent that's much thinner and much more trackable. So for cases of direct carotid injury, we can use a covered stent that immediately stops bleeding. So we have some prospective studies going in that area as well. So it's important not to get tunnel vision with all these new devices because some of these new devices do bring novel complications. This was a case of a flow diverting stent done elsewhere that couldn't be deployed. And so we had to take this patient to the OR. This was removed. Another similar case like that. So I think over time, we're getting a better understanding of how to use these devices, but they're not without imperfections. This was another case done on the west coast of Florida that was transferred after the flow diverting stent damaged the vessel, caused an injury. We had to do a bypass and sacrifice this segment. So I think that's a lot of my motivation sort of on a daily basis, that we've got to be doing things better in the next, 5, 10, 15, 20 years. I think currently our knowledge of the biology of aneurysms is inadequate. A better understanding of the basic biology will lead to improved patient selection and develop of non-invasive therapies. And, I think we've got to be doing better than this. And we're learning a lot about the pathophysiology of cerebral aneurysms, but okay, so what? So what's the relevance of that? And I think that can lead to improved medical therapy, imaging, and as well treatment options. So these are a lot of the in vivo or large animal models that we work with in the lab on sort of a regular basis. And a lot of things that we're working on, this is just one example, but stent modifications where we can provide a surface modification that's less thrombogenic. We can provide drug reservoirs, antibody-mediated carriers, or cellular carriers that can improve how these stents are healing and improve endothelial smooth muscle cell function. So this is one of those stent coatings you can see here, which leads to less smooth muscle cell growth and inflammation. And you can see here improved endothelialization over time. And I think this is going to lead to future clinical trials. So potentially we have patients that are high risk for treatment or low risk for bleeding. A lot of the patients that we initially enrolled in the ISUIA, the International Study of Unruptured Intracranial Aneurysms, potentially could be randomized to new imaging modalities that predict unstable aneurysms or rupture. They can be potentially randomized to a new medication. Currently, we don't have any medical therapies to prevent aneurysm growth or rupture. And then this can also be coupled with new endovascular and hopefully surgical devices as well. So in conclusion, I think endovascular developments are expanding at a tremendous rate. Better models are indicated to improve our assessment of these. This is going to lead to novel imaging for diagnosis, risk assessment and planning, and intra-procedural and follow-up of these patients. Devices can improve our treatment abilities and outcomes. This is also going to lead to novel complications, and we need to have improved abilities to manage retreatment strategies in these problems. The development of these devices can outpace clinical studies, and that's an important thing to keep in the back of our minds, that that's a very important aspect of this, that we need to continue to validate that through well-designed trials. So thanks so much. That's sort of a brief overview of where we've come and where we're going. And thanks everybody and all the companies that have provided funding and support for this. Yeah, it's challenging. There's two avenues. You have to go through the FDA. So there's an acute compassionate use protocol, which is if you have a patient, you know, an emergent use. And then usually if you can get all the paperwork done, which requires, you know, a brief IRB, company approval, and they obviously need to provide the device, and then FDA approval. I mean, you can get that done. We've gotten it done in about 24 to 36 hours with a lot of push. And, you know, that's somebody that, you know, maybe has a ruptured aneurysm where we really have no option for the patient. The more common one is you have a patient that needs some sort of treatment in the next, you know, 3 to many months. And again, we don't have any sort of reasonable device for. So that it's pretty similar. You need sort of a brief IRB, you need approval from the company, you need to submit all that to the FDA, and you need to get approval from the hospital as well. So it ends up being a tremendous amount of paperwork, but for some of these patients, obviously we don't have another option, you know, and I think, you know, obviously that can hold a lot of weight for some of the patients that you see with brain tumors and things like that, where we really don't have a good option for how to treat them. Awesome.
Thank you, Bobby. We just realized Dr. Peterson couldn't make it. I didn't realize that till this morning. So I'm going to go next. And after me, Mike will do that. That perfect gives us a lot more time with our exhibitors and supporters. Okay, so I am going to talk about kind of a new concept with bypasses. Of course, the residents have heard this before and have, of course, participated with this. This is what we're calling the 1D2R bypass for Moyamoya and steno-occlusive disease. This has already been published, but gives me a chance to perhaps go over some of the basics here with the younger crowd. For us to understand the physiology of bypasses, we need to understand a few basic physics, hemodynamics concept. One of them is Bernoulli's equation. The other one, which is a lot more relevant, is the Hagen-Poiseuille's law, which is a complete equivalence between electric circuit that I'm sure you remember from high school physics with the fluid dynamic concept. So we'll come back to that. So Poiseuille's law is on your left. Ohm's law from electric circuit is on your right. And the concepts are entirely equivalent between the three items: voltage, current, resistance, same as delta P, flow, and vascular resistance. Very simple linear relationship between those things. When you perform a bypass, there are three geometries usually. You can do an end-to-side. The reason to fish mouth a donor in an end-to-side, as you can see this from an old chapter we've written, because it increases the cross-sectional area by 4 times. That's why you avoid having a stenosis when you do that. When you do an end-to-end, it's nice to bevel it so you don't create a stenosis. And when you do a side-to-side, there's really only one way to do a side-to-side. You have to usually do a running technique on the back wall, and then you do the front wall. Typical applications of a side-to-side is a pica to pica, or an M2 to M2, an A3 to A3, and very rarely a PCA to SCA. A technical question comes up usually is, where do you do your arteriotomy? In a side to side, at the top with 12 o'clock, or on the sides, or in between? And the in between one is what I use because it's the best compromise between better viewing of the edges and better apposition. So it's a nice compromise between those two things. This work, as you know, has been published. We have to thank my former fellow, Nick Khan, for leading the charge, these two publications. You know, we use flow measurements here a lot. So this is what a 1D, 2R would look like at the end. You leave the anterior branch of the STA undisturbed. You take the posterior branch and you do a side to side to the temporal M4. Then the same branch goes and becomes end to side to the frontal M4. So let's go over, if the video will play, a case, 34-year-old, hypertension, young man, actually a nurse in another hospital, overweight, and the neuroimaging findings are here. You can see the watershed ischemia in the left hemisphere in a 34-year-old, and it worsened a few days later. We always obtain neurophysiological testing, including TCD VMR, vasomotor reactivity study. And you can see here the misery perfusion and the increased mean transit time on the left hemisphere. And there is just even 2 days pre-op, the watershed ischemia had worsened compared to the first MRI I showed you. Some of those patients are really quite unstable, which is why really bypass surgery cannot be exterminated, because many of those studies did not include the so-called hot patients like this patient. COS, for example, had a mean randomization time of 72 days. Angiogram, when you overlap the angiogram injections, you end up still with a bare area that doesn't fill very well. And you can see the STA, which of course we pay attention to. And again, I remind the residents that often STAs look miserably small, but don't give up. When you dissect them off the skin, they open up and they have actually very decent flow. So the rationale for doing this is, of course, to prevent future strokes, augment the flow, and possibly reverse cognitive decline. And there are the usual risks. That's a description of the setup, which we will skip. And that's a surgery. I still like to center the bone flap 6 centimeters above the external ear canal. And it's a linear incision. And the dissection of the STA, the parietal branch, measure the flow in it, fill it with heparinized saline, put some papaverine around it so it doesn't go into spasm, use the Colorado needle to open the temporalis, make a small, fairly small round craniotomy, open the dura. By the way, opening the dura, you want to make sure if there are significant middle meningeal artery supplies, you want to save them. And then you put that self-suctioning Spetzler microvac device. You identify your 2 recipients, one on each side of the Sylvian fissure. And here, then we measure the flow. Again, I have no financial relationship with the company. I've used the transonic flow probe for more than 20 years now. And you get the flow measurements, you record those, you clean the adventitia. And now you have a choice. Do you do the end to side or the side to side anastomosis first? I've done it both ways. This particular example shows you the end to side first. So you do either an interrupted or a running technique with a 10-0. And now we remove the clips, we measure the flow. And that's step one, as I'll come back to later to show the sequence of steps. And at this stage, I can decide, do I need a second anastomosis? Is the flow too high? And many times I've quit after the first anastomosis because the flow was already quite high and I'm worried about hyperperfusion injury. In this case, it was 58 cc per minute. And you notice I kept moving the STA in different locations because sometimes it can kink on itself. And you have to make, that's the beauty of doing the flow as well. You can fine tune how to position the donor. So we proceeded with the side-to-side bypass. Same thing, not same thing. This is a side-to-side, not an end-to-side. I'm running the back wall and then the front wall. No, remember the number was 58 after the first anastomosis. We now remove all clips. There is your 1D, 2R completed. Now we're 63. And again, the brain of the patient are smarter than us. The brain knows exactly the supply and demand equation. It will take what it needs. And that's what happens with these cases. That's the ICG. So here is the advantage and disadvantages of the so-called 1D, 1R, the single barrel versus the double barrel, the 2D, 2R, or this, what I just showed you is the 1D, 2R. Of course, the advantages is that you keep the other STA branch intact for perfusion of the skin. It's always there for in the future if you need more bypass on this patient. It's, of course, quicker to do a single incision. There is no point doing the 1D, 2R if the bifurcation of the STA is high. If it's high, your craniotomy is at the bifurcation. You might as well use both branches. So here is a list of the flow measurements on this particular patient. We started with a cut flow of 46. We ended up with 63. So this is higher than 100% cut flow index. This is the literature on urgent bypasses and so forth. That's a view as I showed you. So that's your typical example. So it's, as I said, it's like an electric circuit in parallel. You have two parallel options. And as you remember, again, perhaps from high school physics, the equivalent resistance of a parallel circuit is 1 over R, the sums of the 1 over R's. So here are the 3 steps of the surgery. You identify the two recipients. You have your donor. You usually do the side-to-side first. You measure the flow. Then you do the end-to-side next. You measure the flow of the first anastomosis and then the second anastomosis. So the first anastomosis will have 2 measurements. The second one will have 1. You'll see why, how we use those concepts in a second. When we wrote this last year, we looked at 21 cases, all 100% immediate bypass patency and 90% delayed follow-up. The cut flow index, the ratio of total bypass flow to the cut flow of the STA was 0.64 after the first anastomosis and rose to 0.94 after the second one. This shows you the benefit of adding the second one. Here is what happens chronologically. On your left is the mean cut flow of 57. It drops to 36 mean after the first anastomosis and becomes 51 mean after the second anastomosis. Here is a comparison whether I did them side-to-side first or end-to-side first. At the end of the day, it did not matter regarding flow measurements. Here is the clinical outcomes. Of course, what matters is MRS. And of course, those patients have gotten better. Orange is post-op, we shifted for lower MRS. There is some supplementary material with the paper kind of getting into the equations and so forth. So that's the benefit of the second anastomosis, is that it increases by 40%. It decreases the peripheral vascular resistance from 40% to 17%. So that made us think of new concept to add to the CFI. We call them SARA and SASI. SARA is second anastomosis relative augmentation, which is when you divide cut flow index final by cut flow index initial. And SASI is second anastomosis sink index, is a similar concept, but it indicates how much the second anastomosis sumped from the first one. This is a typical case. You can see a very nice mature bypass at 1 month post-op on your right. And this is the only patient in that 21 patient series that occluded, and occluded bilaterally in a delayed manner. To show you, as I speak about many times, is some patients have an excellent ability to grow indirect collaterals. And that's what happened in this patient. And their direct bypass atrophies over time. So here is this patient. On the top is his right side. On the bottom is his left side. The top side, you can see immediately post-op, nicely patent. And then 1 year post-op, the bypass is almost all gone, but he has excellent indirect collaterals. He then did the same exact thing with his left side, again, to show it's not a technical issue, it's a biological issue about some patients. Why? We don't really know. Is it EGFR related? Who knows? That's another comparison between the 3 types of bypasses. So the benefit is that you shorten the length factor by adding that second anastomosis, and therefore you decrease vascular resistance. And you create, and you know that you've benefited hemodynamically because there is the mean SARA in that series is 1.79. The mean SASI is 0.4. So the conclusion is that this is a good technique to use for all the advantages I mentioned. And I'm not presenting to you today the overall series of all the moya and ischemia cases with all types of bypasses, but the conclusion from that series is that, of course, it's not controversial that you need to know how to do bypasses for moya. It is certainly controversial in cerebral ischemia, but the point that the larger series would make is that if you select them properly, you can certainly demonstrate benefit. The combined MNM was 3.7% from the large series compared to the cost of 15%. But that's another talk, another time. Which is why we need to keep your residents interested in cerebrovascular surgery, adept at doing bypasses, because as you know, there is a small but very important niche for it still today, in spite of the beautiful endovascular advancements. And I'll stop here, answer any questions. Yeah. No, it's a very good point. No, he did not have sickle cell disease. Sickle cell disease is tougher. They can occlude more. As a matter of fact, we're writing a paper right now about complications of transradial angiogram in sickle cell patients. Evan has written a very nice manuscript. So no, this patient did not have, and by the way, he's doing perfectly fine. They occlude without symptoms most of the time. Okay. Oh, hey, Mike.
I was listening, but I just want to know, can you use a fluid 100 kind of make some of those measurements at the time of surgery, or are you just relying on all of them?
No, I do both. So with the yeah, ICG and the flow.
But the score, that score that you're doing, analysis, are you doing that measurement with intraoperatively or?
Intraop. The SARA and the SASI,
Yeah, yeah.
intraop. It's essentially a ratio of cut flow indices, you know, after the first and after the second.
Flow measure, not with the flow measure.
Correct. That's a direct transonic flow measurement. Yeah. Well, if it's very high, it's too late. I've already done that. You see what I'm saying? What I haven't so what I don't know is I do the first anastomosis. I mean, if I get 70 or 80 cc per minute going in, I'm probably not going to do the second one unless the angiogram tells me that the two territories are isolated. As you know, moya moya, you get pockets of isolated territories that so that also plays with it. I don't have an exact algorithm, but kind of that's how what I go through when I decide. I think that I just have it on those 20, 30 patients now. What I'm doing is now prospectively collecting them. It'll be interesting to see if I get, let's say, hyperperfusion injuries with a certain SASI range. And so that's probably more useful prospectively than going back. And as we said in the paper, we kind of encourage other centers perhaps to use it. And maybe we can collate, how many of these cases, unless you're in China, where my good friend Xu Bin does 900 bypasses per year, 900. I mean, just think about that number. Does 1,300 cases a year, everything, of which 900, anyway, this is, anyway, I'm going to stop here. Yes. No, I don't, I'm sorry. I mean, VEGF, I'm talking about. No, it's not, not GFR. Sorry, I misspoke. Vascular endothelial growth factor. Okay, Mike, take us home with the exciting brain tumor innovation.
Oh, perfect. All right, great. Well, I'm glad we have extra time today because I did have a difficult time trimming this down to just the 20 minutes. But if you guys need to go consent your patients like I did this, I won't get disappointed if you leave early. But I think what this is a pretty exciting and interesting talk that I put together on kind of the future of what I think of brain surgery for tumors. And it talks about maximizing resection without sacrificing neurocognition. Here's my disclosures and funding. So I think we all understand that with brain tumor surgery, the goal is a maximal safe resection, right? We want to increase the amount of tumor resection we do and preserve function. But what is actually maximal safe resection? Maximal is what? Maximal based on an MRI scan, which is just an estimation. So it's an estimated maximal resection. And what's safe? Safe is just what if they could walk and talk. I mean, that's what we kind of contribute to being safe, right? But we know there's a lot more to it. In fact, Alexis and I actually had an interesting patient in clinic on Tuesday, a patient who had a tuberculum sella meningioma. We resected it. Case went perfectly, no transcortical approach. Everything was extraaxial. Vision improved, patient did well. But she's a vice president of a financial company that was doing legal contracts for hospitals, and she can't comprehend the legal contracts anymore to a point of where she could manage 55 people. And so what happened with that? Was that a safe surgery or was that not a safe surgery? I don't really know.
So what does the data show? Well, the data shows, I think we all very well that improves cytoreduction and improves survival for malignant cancer, whether it's the first resection, the second resection, the third resection, or even the fourth resection. But again, this is based on an estimation, right? You're using preoperative MRIs and postoperative MRIs where we think the tumor is. And we've done this too. Both Rick and Ashish and I have published kind of our case series of supramaximal resections for eloquent and non-eloquent areas. And we've shown that we could improve survival in these patients. But were they safe? Were these patients able to go back to their jobs and work at high functions? We don't know. So what has really happened in brain tumor surgery in the last 50 years? What have we developed to actually help brain tumor resection or safer surgeries? So with better tumor resection, we have MRI with gadolinium, advanced imaging, although I would say most people don't even use that, MR spectroscopy, MR perfusion to guide their surgery, intraoperative fluorescence, which has just been around for about 2 years. And how about safe surgery, navigation, tractography, functional MRI, neuromonitoring, intraoperative mapping. So we use all these, no question. I mean, here's me at UMH doing a 5-ALA case, and you can see there's definitely benefit to understanding where the fluorescence is and how to resect that. But when it comes down to it, when we talk about just the better tumor resection, all these things just approximate tumor. None of them actually give data, right? It's just MRI is approximating where the tumor is, advanced imaging is approximating where the tumor is, and an intraoperative fluorescence still is only about 90% sensitive and specific with approximating tumor. So what else is there? Well, there's pathology, frozen sections. Fortunately, nothing's changed since 1905 when frozen section was developed, which was the same time of these other current events were ongoing. But recently we have made kind of an innovation with that, and that's with Raman microscopy, which we've started using here. It's developed by the Michigan group and also this company called Invenio. This is what the machine looks like. And basically what it does is it is able to take digital histology pictures of the specimen with only one step versus the 14 steps that this conventional frozen would take. So we've cut in time down from 45 minutes to 2 minutes, and the digital picture could go down and go into the OR. And you could see that when we look at the frozen compared to Raman, the histology characteristics are very siterminal. So meningiomas, pituitaries, glioblastoma, and kind of that small increasing from normal brain to high glioma. So can you use this for lesion guidance? Well, we're starting to look at that. So here we could see a glioma that we resected, that I resected about 18 months ago now. We can see in the middle necrosis, outside ring enhancing, and then we have the outer flare here where we could start to get it back to normal brain. So you can start to see that you could detect this now with margins. Here's an invasive meningioma that we did, and we used it for, you could see, you could detect the meningioma, you could detect that there was actually atypical meningioma by kind of this necrosis that was laying in it. You could see how the meningioma is invading into the muscle, into the bone. Bone you can't see on frozen section because there's too much artifact. And then we got up to the lacrimal gland, we took a piece and there was no tumor there, and that helped us understand that we didn't need to resect that. So we looked at this about a year ago, just trying to correlate if this is a useful technology and validate it. We actually identified that the frozens by SRH were actually more sensitive in determining lesion by about 2% than a frozen section, using our own pathologist to understand it. And we showed that without an efficient workflow at the time, without Wi-Fi and everything built in, we were able to lower the time for frozen to 8 minutes from about 40 minutes. And I would argue that now that we have it embedded into our Wi-Fi and PAC system, we can get that down to less than 2 minutes. So now when I operate and I do glioma surgery at UMH, this is what it looks like. I have my pathology screens up above. We have the machine in the room, and basically we send off these frozen sections, and we can actually look at the pathology as we take the frozen sections without even kind of getting up from the chair. So that's great, but what can we do next? These are digital images, and can we analyze them and understand without the pathologist if they are in fact tumor or non-tumor? So we worked with the Michigan group, and they were working on this project to basically understand if you use deep learning to assess the pathology. And so they categorized, we were just looking at actually the type of pathology at that time point. So the top 10 diagnoses of brain tumors. And then we basically looked at to see if you could identify the top 10 over 386 samples. And we were a cohort with Columbia and Michigan. And in fact, it was 95% accurate with determining within 2.5 minutes, what the pathology was. So we've taken that, we've worked with the company Invenio now to translate that into actually, can we decide, can we tell if it's actual tumor margin or not, which is a whole different question. And so now our system has this kind of non-FDA approved kind of software on it that will actually give you an AI analysis of the tumor margin in real time during surgery. And so here, basically, you could see that this pathology and red being tumor, it'll give you percent here of how much of that specimen is actually tumor versus green here, where it will tell you that this is mostly non-tumor. And so we're starting to kind of look at that with, So for the first time, we'll be able to actually collect data and information during surgery to actually give the surgeon actual information as to whether or not we should resect that tumor or not, which is more than just an estimation or approximation. So let's just move over to the safer surgery side. What have we done in the last 50 years to improve the safeness, navigation, tractography, functional MRI neuromonitoring, and nerve mapping? Again, we congratulate ourselves when we preserve motor and speech, but we know that there's a lot more to it. So how can you tease out the differences between all the other neurocognitive functions? So in that, we turn to connectomics, which is basically the comprehensive description of connections between every part of the brain using non-invasive imaging. So why should we care about it? Well, every neurosurgical problem that we deal with patients have neurocognitive problems. And basically, what do we do to assess them? Well, we have a very limited amount of tools: verbal history, exam, imaging, and basically using 10 data points to kind of analyze a 25 million dimensional problem and connections in the brain is just not really enough, not sufficient for us to analyze this. And so what we need to know is basically how every brain functions and how we can preserve the quality of life in every one of these patients and how each one will be affected slightly differently. And so what we're using right now is basically this, an MRI, which is on the left, which tells us the structure. What we need to know is basically the wiring diagram and how the brain functions. And then basically every clinical implication it takes when we manipulate those wires. And so we have these outdated models, which we're learning more on. So for instance, when I was in medical school, this is what the speech model was, which is Broca's, Wernicke's, and the arcuate fasciculus. But we know now that the language network is actually much, much more complex. And in fact, recent publications just last year showed this kind of novel model of all the language pathways. And you can actually see the connectomics here on how we could actually show that for each individual patient. So when you talk about quality of life, it's not just motor visual language. It's actually all of these other things, like the patient that I talked to in the beginning. How do you preserve their executive function, metacognition, their memory, their empathy? We just don't have time to ask all those questions and to do 4 hours of neuropsych testing on every patient, both before surgery and during surgery. So we've turned to, we turn to this patient here who has a left glioma and left temporal lobe. And we talk about how speech is important in this case. But I would argue that actually all of these networks that are touching this tumor are critical. And so we must look beyond what we would typically ask for, which is speech and motor, to kind of try to preserve these functions. And I'm not going to go through every pathway and what it means. We all know visual, sensor, motor. But just to give you an example of some of what these pathways do is when we look at something called the dorsal attention network and how the salience network, which are two networks we really typically don't talk about during brain tumor surgery. Well, these are networks that affect us right now as we're here. So if you're paying attention to me and you're looking up at the screen and you're listening, you're using your dorsal attention network, which is being triggered by your salience network to kind of become primary. But if you're thinking about the case this afternoon or how you forgot your girlfriend's birthday party that's happening this weekend and you're kind of like, struggling on that, well, you're not really paying attention here. You're kind of internally monologuing and you're using your default mode network, which is your internal cognition, and the salience network is talking to you that. But how do we tease that out when we're doing brain surgery about if these networks are being affected and can somebody do that afterwards? So, well, we atlas the brain, and the Brain Connectome project, which was done in 2016, was able to kind of parcelate out over 360 different parcellations, and it's very straightforward when you have normal patients. But when you start looking at brain tumor patients, everything becomes more complex. So we've been working with a company called Omniscient, which uses big data and artificial intelligence to take functional MRIs, DTI, and rest day fMRIs, rebuild a person's connectomic tracts, and understand how these are being kind of moved around by the tumor or pathology. And you can see that it does a very good job. So for instance, this is a patient here with a large thalamic glioma, and you can see that it actually was able to identify that the caudate patema has been pushed up by about 3 centimeters anteriorly, and tease out that they are still connected and in fact intact. It has edema correction, and basically uses AI to correct and kind of provides a better realistic tractography and connectome for what functions of the brain are there in every patient. And so how are we using this today? This is a case of a patient with a parietal met. I think there's several different options of how you would approach this: superior parietal, inferior parietal, superior temporal, and there's risk and benefits to each one of those. But for this patient, what would you specifically choose? Well, if you look at the connectomics, we just pull out the visual tracts first, and we can see that they're posteriorly as we expect. And so you definitely want to go above that. And you could say, okay, well, we're going to just trick any kind of target that would be above that. But if you add in kind of so we picked out this track here. If you add in the non-dominant language network, which will help you with some of these more complex skills, you could see that actually that was right in our initial targeted track here. So we moved the track of our approach a little bit more superior to avoid all of these different networks, and to find a silent corridor to get to this tumor to remove it using a transcortical approach. Here's another patient, and this patient did well. Another patient had an anaplastic astrosoma and now has recurrence, a large left frontal flare enhancement that was growing over subsequent scans all the way back to the kind of the motor cortex. And you can predict that this is in the SMA syndrome. And so we did this awake, we mapped him out. He did fine throughout the entire surgery, very minimal changes, but postoperatively he woke up completely aphasic. And so, is this something that we did during surgery? Is this an SMA? Is it going to get better? How is it going to get better? So we looked at the connectomics, and SMA syndrome, although we've all heard about it, we understand the location of the brain, how it's connected and why it happens and what networks it causes it are actually not known. And so Mike Shagru, who we work with this product, has this idea of initiation axis with the DMN, salience, and SMA all together are what would form a more permanent SMA syndrome. And if you take out different parts of this, it would be more permanent than temporary. And so we looked at that to see if this was intact, and we found out postoperatively, in fact, all these networks, the DMN, salience, and SMA were all intact. And so then why did the patient get an SMA syndrome? So we pulled out that, in fact, the patient postoperatively was missing these very small tracts that are a part of a side group of the initiation axis, 45, 47I, and IFJ, and which are non-dominant aspects of this tract. And so the patient actually ended up doing better, but we could have predicted this by knowing postoperatively that the main tracts were intact and it was just these small subsidiaries that were affected. And we could have predicted at that point in time that the patient would recover in the next several weeks. So what is this moving towards? Well, it's moving towards theoretical brain surgery. Can we simulate a surgical resection in a specific patient with a specific tumor before they get operated and kind of identify exactly what neurocognitive functions they're going to miss before we even touch the patient? Are we there yet? No, we still need to understand basically how these connections are formed and how they're connected. So it's much more than just, is the wire broken or not? The brain is obviously much more complicated. So for instance, there's something called hubness, which is how many times the wires come together and separate throughout the brain. And everybody has a different amount of hubness and connectivity within their brain. In fact, if you look at the eloquent areas of the brain, of the top 10, 6 of them are actually what we are currently categorized as eloquent areas. So this hubness is actually a very critical part of the brain. Additionally, there's another idea called PathLink, which is associated with global efficiency and your IQ. And that's how efficient your brain is getting from information from point A to point B. And the amount of hubs and the direction that it takes to get to this is basically how quick you could do these very, very fast connections and very multi-dimensional analysis. And so when you operate on somebody, you do a large frontal lobectomy, yeah, they still may be able to get from point A to point B, but now the path link is truly affected because it has to go a tremendously different direction. And so if we understand this, we could say, okay, well, you already have poor hubness and poor path length. The right frontal lobectomy in you is going to have a serious effect. We're not sure if you're going to go back to work. Whereas somebody who has much higher global efficiency, they may not be affected. The contrary may be the opposite. Maybe that person who has really good efficiency and hubness has an IQ of 160 and is operating as the president of a company or business, and any change in their global efficiency or hubness may bring them down from the level that they're currently experiencing. We don't know the answers, but that's what we need to find out. And this is the first tool that's really come out there that we could actually start quantifying the differences. So how would theoretical brain surgery work? It would kind of work something like this, where we would have the tumor in there. We would basically understand what tracts and global efficiency and hubness is affected, and then make those cuts and kind of look at that. And that's what we're doing in the clinical trial, which is the Brain Lesion Connectome Project clinical trial, which is multi-institutional, and that we should be starting in the next month. So one last thought, and that is when Alexis, who's leading kind of this project on Omniscient, looked at recognized first 100 brain tumor patients that we operated on. We looked at the connectomics of them to try to understand, okay, what is being affected? Are we really affecting these non-dominant pathways as much as we are? And when we looked at the patients who basically have good and bad outcomes, the patients on the left have normal, perfect outcomes per the note, right? And the left side have an effect. And when we find out that, in fact, non-eloquent areas, or areas that we wouldn't traditionally call eloquent, are actually much more affected than the eloquent areas. In fact, the patients without neurological deficits had 83% of them had at least one of the networks affected, even though they had no neurological deficit that we found in a note, right? Which is, again, looking at motor, sensory, and orientation. So there's a lot of these patients are being affected by non-eloquent areas, the non-eloquent networks that are being injured, but we don't really understand what those are being, what the final effect and the long-term effects are those, and we need to look at that. When we look at them here, there was a significant difference in basically the non-eloquent areas being more affected than the eloquent areas. So we're just scratching the tip of the iceberg. So I hope I've convinced you that the future of brain tumor surgery is going to be much more precise with our tumor resections. We're going to have data actually to understand when to resect tumors. And now we're generating data to understand when not to resect tumors. And only when we understand both of those can we really optimize what we're doing in these patients. Thank you.